So good morning to everyone, ladies and gentlemen. So back on ACL injuries. ACL injuries are severe injuries and should not be oversimplified. You see, this is not an easy injury, and we have just heard how much it's difficult to return to play at the same level, avoiding another injury. So my presentation will be divided in three main parts. First of all, I will speak about time and criteria after ACL reconstruction, a difficult balance to be found, how to use your time after ACL reconstruction, and our original data on our experience about secondary targeted neuromuscular training. But first of all, this is an important concept that Kate touched very well. After ACL injury and reconstruction, we have two main outcomes. The first one is return to play at the same pre-injury level. And this is not easy. And on the other side, we have the second ACL injury risk. So my presentation will be mostly about the second ACL injury reduction strategies, but bear in mind that there is also the other outcome, and the patient asks also the other. This is a secondary injury, a graft re-injury. You can see very well the mechanism. So the point is how to minimize the risk. So discussing about time after ACL reconstruction to return to play and second ACL injury rate, this is an over-discussed topic. But in the last 12, 13 years, these are the most relevant papers published. The first one, published by Shelburne, 1,400 patients, 136 second ACL injuries. They found no difference in second ACL injury risk if return to play was before or after 6 months post-operatively. But they didn't perform a month-by-month analysis, and all patients were bone patellotendon bone graft. The second study is a new study, very famous study from the Oslo, Delaware cohort, 100 patient follow-up, 28 knee re-injuries. The authors found an interesting 51 knee injury risk reduction for every month you wait until 9 months after surgery. And the last study is a study on 85 very high-risk patients from Duke University, so all teenagers, 27 second ACL injuries. The author stated no significant difference in absolute return to play time, but there was a statistically significant 13% second ACL injury risk reduction for every month you wait to return to play. So now you know the data, and you can have your own idea about return to play time after ACL reconstruction. But discussing about criteria and function, so we know that passing return to play criteria does not fully protect from the second ACL injury. And I think that Kate Webster explained really well this concept. We also know that achieving the current return to play criteria is not so easy. According to Wembley and colleague, at 9 months, only 11% of patients pass current return to play criteria. And this result is pretty consistent in the literature, 30, 40, 44, but no study above 80% of satisfaction. So if you speak about the second ACL injury, we have to speak also about biomechanics and neuromuscular control. As we know, the biomechanical factors are associated to second non-contact ACL injury risk in young and mature athletes. So trying to merging everything together, we have seen that different time frames have been proposed to return to play after ACL reconstruction to minimize the second ACL injury risk. One group, and you will hear him after me, proposed to wait 2 years post-surgery. On the other hand, we know that return to play criteria are difficult to achieve after ACL reconstruction. And maybe we have to ask ourselves, are we applying inadequate rehabilitation post-surgery? The third bit is that time alone, at least alone, does not fully explain function after surgery. So, is it a matter of how we use our time after ACL reconstruction? We should speak about compliance of our patient in rehabilitation. We need the correct volume of therapies, the correct number of sessions, and the correct frequency of sessions per week, in order to achieve rehabilitation goals. And this is a really important goal. Complete isolated strength recovery of quadriceps and hamstring strength muscles. So this is generally one of the most limiting factors of not passing return to play criteria. And again, are we applying enough volume to achieve this result? Also, it is suggested by current clinical practice guideline to apply qualitative movement assessment, and we saw a bit also from presentation. This can be used to target a neuromuscular training intervention in order to have a secondary prevention. And also, we are really pushing on the adoption of on-field rehabilitation, really as a bridge between indoor rehabilitation and return to train. So the real question now is this one. So do we need more time to achieve, to fulfill all these criteria? Well, probably yes. But we think that the point is how you use your time, or how you use more time to achieve a successful outcome, and not time itself. So the second part of my presentation will be based on neuromuscular training and on-field rehabilitation addictions. And really, sports probably matter, but your approach more. You can see this is a first ACL injury happening in an NBA player, same knee, same mechanism, same injury. Graft injury. So I will show you 3 case scenarios. This is the first case scenario. I'm sorry to say that this is the practice nowadays in many cases, and it happens to everybody. So there is a drop of function after ACL injury, and another drop after ACL reconstruction, and we have the typical rehabilitation progression. And the player stops rehabilitation, the patient, at some point inside generally the strengthening program. So we estimate 60% of function. This is just theoretical. So adding a target neuromuscular training can, in this way, you can add more time, but also function. And maybe you can increase a little bit. But you can do that only if you did very well the first phases. Because without isolated strength, it's nonsense to go into functional strength. The third case scenario is adding again, another stuff, a on-field rehabilitation program. And you can see, again, more time and more function. But you can do this only if you completed before a nice neuromuscular training intervention, so that it is really ready to go on the field and to progress till return to train. So in the day-by-day scenario, this is just theoretical, but you can have many lines. You can have early recovery, little bit delayed recovery, average recovery, but I guarantee, if you really decide to complete the functional recovery, your average return to play time will be also longer. So this is our late phase rehabilitation concept after ACL reconstruction. So first of all, there is strength. Strength comes first. So the first strength assessment, Isokinetic test or isometric test, is what we want to achieve. So the objective for us is having a deficit lower than 20% for quad and hamstring strength. Then we can add a target neuromuscular training based on a qualitative movement assessment. So we keep on working on strength to reach 0% deficit. And then, when the movements are okay, indoor, you can go outdoor to really complete the program. And you can see that in this way, with these 2 addictions, you gain function and you also gain time. You use more time. So this is a test we are applying. It's based on experience of Christopher Powers. That's my teacher and spoke yesterday. It was a great honor to have him here. So it's a frontal sagittal plane analysis of 6 basis post movement with 5 evaluation criteria, and with a scoring system out of 100. So basically, a score lower than 70 is considered non-optimal. So the test is important to give an immediate biofeedback on the video to our patient, and also crucial to customize our neuromuscular training intervention. And you will hear this afterwards by Tim Hewitt. On the other side, second addiction, the on-field rehabilitation program is a stepwise program with 5 periods with the goal of complete sport-specific recovery after ACL reconstruction. And we introduced this program in 2012, but we have been using this concept for 20 years. On-field rehabilitation stands between standard rehabilitation and return to training with the team. And we use this in order to avoid these big spikes in load that typically happen between rehabilitation and return to training with the team. And we are updating this program with a 2-part paper that are in press now in JOSP, and we also introduced the GPS monitoring in it. So moving forward, and arriving to the third part of my speech, these are our original data and experience about quality movement assessment, neuromuscular training, and second ACL injury. So this is a busy slide, but you can see that this is a fairly big cohort of more than 300 ACL reconstruction patients. You can see the technical activity scale, average 8.1. At least they perform 1 qualitative movement evaluation before return to play. And we didn't involve only compliant patients, but also non-compliant patients. So, result, we had a 84% return to play at the same level, the same sport, so very high return to play rate, if considering also what we saw before in previous cohort of our patients, and a 6.1% second non-contact ACL injuries. We have 16 second ACL injuries, 2 direct contact that were excluded, and 14 non-contact or indirect contact. So basically, our qualitative movement assessment was correlated to the second ACL injury risk. So look at that. If you have a movement analysis test scoring lower than 70, blue line, you had a 5-fold increase in the likelihood to having a second ACL injury. And also, more significantly, if you take a look to the last movement of our analysis, it is the 90-degree planned cut maneuver. The patient that had bad mechanics, bad cutting pattern, had almost an 8-fold increase in the likelihood of second ACL injury. And these results are corrected for age. So this is the pattern we learn to avoid. This is at least our experience. This intra-rotated cutting pattern with dynamic knee valgus loading, contralateral pelvic drop, coupled with non-optimal knee flexion in the lateral plane. So this pattern put a lot of tension on the pivot. But the good news is this. So if you couple bad mechanics or good mechanics with compliance to the neuromuscular training intervention, you found 3 groups. The first group, red line, bad mechanics, and incomplete training, 14% second ACL injury. The second group, orange line, good mechanics, MAT over 70, but incomplete training, 4% second ACL injury. If you have good mechanics and complete training, at least 12 sessions of secondary neuromuscular training session, 0% second ACL injury risk. So these are good news for us, for everybody, I think. So take-home messages. Return to play and second ACL injury prevention are both crucial outcomes following ACL reconstruction. And I think that we should balance them. Time is your friend. Use your time, or more time if needed, to really complete the functional recovery. Late-phase rehabilitation addiction should be considered after ACL reconstruction, especially in this extent. And the use of neuromuscular training is correlated, in our experience, to a lower risk of secondary ACL injury. Thank you very much for your attention.